So very good morning to everyone. At the outset, I'd like to thank the organizing team for curating such an excellent scientific schedule and really giving value and importance to all the aspects of pain in the scientific program. So the topic that I've been given is nutraceuticals in neuropathic pain and fibromyalgia. My previous speaker, Dr. Chinmay, has really set the tone for nociplastic pain. So if you take just two key points from his lecture, the most important aspect was that there is no particular nerve damage in nociplastic pain, and there is a lot of research and evidence yet to be generated that why is this nociplastic pain happening. All right. So with that background, I like to say that why are we talking about this topic? Why is it so important that we need to give nutraceuticals to our patients when we have definitive therapies like milnacipam and duloxetine? So as pain clinicians, you would have seen that many a times, despite all your best efforts, counseling, non-pharmacological measures, your patients keep on coming back to you and say that we do not have that adequate pain relief. So the underlying mechanism, since it is poorly understood, lies the fact that we still do not know what is happening in the body. And that is why a major chunk of the patients keep on coming back to us saying that we do not have adequate pain relief. So the main important aspect here is that a lot of patients come to us after referring to Google, a lot of doctor shopping, and then turn out to you as pain physicians. They obviously want to recommend that we want to take something over the counter, maybe some naturopathy. There's a mix of Ayurvedic, homeopathic medications as well going on. So you can't really say what is the formulary, and they are not regulated substances. So ultimately, the key role is of the pathophysiology, like Dr. Chinmay mentioned. You need to understand what is the role of central sensitization in these patients. There is certainly a major chunk of neuroinflammation that is happening, especially in the neuropathic segment. And that is what is reflected in your investigations as well. In addition to this, an autoimmune component has also been tested for nociplastic pain. However, it is yet to be proven. In addition, of course, there is oxidative stress, and reactive oxygen species form a major chunk of leading to that vicious cycle of pain begets pain. So let's look at what are the common nutraceuticals that we use. First is alpha-lipoic acid, one of the substance which has, I would say, the greatest evidence for neuropathic pain. It is ultimately a potent antioxidant, and it improves your mitochondrial bioenergetics, which is modulating your NF-kB. Now a little word about NF-kB. What exactly is it? It is a nuclear factor kappa B. It is a protein. It works on both intracellular as well as extracellular. It is a way of signaling the cell that there is something wrong. Now, what is that something wrong? We don't know. So there is a mechanism inherent in our body which fights against autoimmune, bacteria, viruses, and ultimately signals the transcription of these genes. So a lot of drugs that I'll be talking about are based on this pathway, NF-kB pathway. Now, alpha-lipoic acid has been tested upon diabetic neuropathies primarily. However, there is a lack of evidence for fibromyalgias. Moving on to acetyl L-carnitine, which is the second most tested agent, and similar to our ALA, it also works on a similar mechanism of mitochondrial bioenergetics. Now the beauty here is you give a single shot of ALC to a patient and expect miracles. Of course, it's not going to happen. You will have to give a sustained, at least for about 16 to 18 weeks. Remember, these are micronutrients. These are not precision or targeted therapies like we are used to, in terms of radio frequency, in terms of anti-neuropathic. Those are really gunshot or rifle kind of a sniper technique. This is more of a shotgun. You would have to include this as a part of an adjunct. This cannot be a sole therapy. Moving on to omega-3 fatty acids. This has recently, in another decade, I would say, gained a lot of importance in cardiac medicine per se. in terms of cardioprotective mechanisms. So hence, that was translated into the neural pathways as well. And it was shown that these EP and DHAs ultimately also have a modest direct analgesic effect, but again cannot be used as a sole agent. The evidence in fibromyalgia, however, still remains poor. Moving on to palmitoyl ethanolamide, which is PEA. Now, this is unique in the sense it also works on your endocannabinoid system, plus it has some anti-inflammatory properties. Talking about evidence, there are some RCTs which are suggesting that, it has a beneficial role. However, there is no clear-cut guideline to actually demarcate that. Moving on to one of our favorites, vitamin D. This is something that I'm sure a majority of us often prescribe to our patients. Now, if you draw a corollary, there is certainly vitamin D association, a temporal association in patients who have chronic pain. However, directly vitamin D cannot be attributed to any chronic pain. Now, vitamin D, as we understand, it's a fat-soluble vitamin. It plays a role in signal transduction through the transcellular membrane. However, if we start treating all pain patients with prophylactic vitamin D, it has been shown that it has no role. So if there is a documented evidence that there is a deficiency of vitamin, sure, you should go ahead and treat it. Prophylactically giving vitamin D to all patients with the current evidence is not recommended. Moving on to the new kid in block, magnesium. This has really come again from the point of view of cardiac medicine, where this was thought to be a smooth muscle relaxant, and hence people started trying it. In addition to that, we also know that there is a NMDA action to it, and just like ketamine, it helps in neuromodulation and descending inhibitory pathway. So magnesium, particularly in this scenario, is really important. Why? Because it is also shown to improve the sleep quality and decrease the lag time, which often, as you know, can be a symptom in fibromyalgia or a nociplastic kind of a pain. So maybe adding magnesium would be, as an adjunctive therapy, would be fruitful. However, strong evidence documenting that it will help in fibromyalgia patients is still lacking. Coming to the next one, curcumin. Now, this is particularly an analgesic as well as anti-inflammatory action. The clinical reality, however, is that there is no evidence promoting the use of curcumin. Now, why is fibromyalgia so important, and why are we, dealing with all this? Like I said, there is two drugs which is currently FDA approved, milnacipam and duloxetine. This is often the first line of treatment. Like my previous speaker said, there is a host of symptoms in terms of GI, bladder pain, and sleep disturbances. So we will be treating all of that together. There is a psychosocial component in fibromyalgia as well. So if you try to correlate these nutraceuticals to each of these extra pain symptoms, you would really understand that these nutraceuticals are acting as a cofactor or an adjunct. So when we say that these nutraceuticals do not have an evidence in nociplastic pain, are we actually checking for nociplastic pain is the question that remains to be answered. If, say, supposing I incorporate exercise programs, sleep optimization, and psychological therapies, and nutraceuticals like magnesium, ashwagandha, or maybe bromelain from pineapple, it can be incorporated into the system. That is when we can adequately say that these nutraceuticals will work for the patient. Now, a drawback. Why do guidelines do not advocate it? The whole idea of doing a multifactorial regression model in this such patients is that you need to identify the weight of each nutraceutical and compare it to the disease process. Now, can we actually practically do that? Of course not. If you try to translate that protein and study that biomarker, that, okay, this is what vitamin D and ALA has synthesized, and I'm estimating it, quantifying it, that is when you can objectively say that this is going to work. Until then, it is all speculations, and of course, they work as cofactors, and you cannot optimize really all the patients into one go. Say, for example, there's a vegetarian patient and there's a patient who really enjoys his fish. Omega-3 fatty acid levels would obviously be baseline it would vary in both these patients. So hence, the patients would not yield same results with supplements such as omega-3 fatty acids. So what do we do? I mean, where do we stand after all this evidence? So first, identify what is your appropriate candidate or your patient. Treat the patient, listen to them, and maybe document what is their expectation out of your treatment plan. Prescribe what is as per the guideline in terms of anti-neuropathic or anti-nociplastic pain. In addition, also listen to your instinct. If you feel that the patient is still not relieved of pain despite of all your best efforts, maybe it is a time to include some of these nutraceuticals into the drug regimes as well. Remember, these cannot be a replacement of the actual therapy, because that is what the future of pain medicine is. We need to be talking of precision medicine. And till the time we have robustly designed RCTs where the patient population can be homogeneous and that can be attributed to nutraceuticals, till then it is all speculation, like I said. So how do we ultimately decide that does this work or not? The future is biomarker, and like I said, we will have to go for gene translational studies to understand what cofactor is actually missing and is it attributed to the disease process or not. Epigenetics, of course, like I gave the example of a vegetarian and a fish-eating person, epigenetics play a major role in this disease process. So with that, I leave you with the take-home message. With the best available evidence at the moment, only ALA and maybe some form of omega-3 fatty acids have some role in neuropathic pain. None of these nutraceuticals have a precise role in nociplastic pain. However, all these studies are derived basically from an animal model where the foot pad of the mouse was stimulated and for thermal hyperalgesia was checked. So it cannot be extrapolated into humans at the moment. Thank you.